Hello friends, welcome to the GEMS video on the management of type 1 diabetes. Type 1 diabetes is a challenging disease. However, we do have modern technologies and medications for effective treatment of type 1 diabetes. Type 1 diabetes, as you know, results from absolute deficiency of insulin. This can be the result of an autoimmune destruction of pancreatic beta cells. Eventually, the child or the adult with type 1 diabetes will require insulin supplementation. Type 1 diabetes patients require insulin to be administered throughout the day and night. If you consider the natural or the physiological insulin secretion from the pancreas, you have a basal insulin which is there throughout the day and night, that is a background insulin secretion. And then you have a bolus delivery of insulin which corresponds to the intake of meal, and this corresponds to the carbohydrate content of the meal, so that in normal individuals, whatever be the intake of carbohydrate, the blood sugars remain within the normal range. In type 1 diabetes, in a continuous glucose monitoring, usually the blood sugars are crazy. It goes up and down all the time. There is unacceptable glucose excursions. Considering the pathophysiology and clinical behavior of type 1 diabetes, we have a couple of acceptable therapies based on international guidelines. We have well acceptable therapies, and we do have therapies which are less acceptable, but we are forced to provide to the patients due to limited resources. The most recommended therapy for type 1 diabetes is insulin pump therapy. Insulin pumps will have in it a rapid acting insulin like Aspart or Lispro, which is very much close to the insulin which is secreted by the normal human pancreas. And the same insulin will provide the basal requirements as well as the bolus requirements. There are several insulin pumps currently available, and the one with real-time continuous glucose monitoring is the preferred one. And very recently, the VO insulin pump with the low glucose suspend mechanism, or it's called the threshold suspend mechanism in the United States, which will shut down automatically before the onset of a clinical hypoglycemia, is also available for the treatment of type 1 diabetes. The next preferred one is the basal bolus therapy. You can administer a basal insulin like Glargine once or twice daily, and then 3 or more injections of a bolus insulin, and that is with rapid acting insulins like Lispro, Aspart or Glulysin, which is Novorapid or Novolac or Humalog, or you have Epidra. And these are all rapid acting insulins which are administered 5 or 15 minutes before a meal. The less preferred therapy is with the use of pre-mixed insulins twice daily. Unfortunately, in countries like India, this is the most prevalent treatment for type 1 diabetes. One, because of poor resources, and second, because of convenience. It is very hard for doctors to administer and advise the recommended therapy, since the children going to the schools and colleges would prefer not to have a shot in the afternoon, and the doctors are forced to prescribe 30/70 premix insulins. There are a couple of studies revealing the superiority of an analog premix insulin like Novomix over the human premix insulins like Mixtard in the avoidance of hyperglycemia and in the avoidance of unwanted hyperglycemia in type 1 diabetes. However, the preferred insulin regimen, if the patient is on insulin shots, will be a basal insulin in combination with bolus insulin. One example is Levemir or Glargine as a basal insulin, or the new degludec, which is approved for use in above 18 years, and a bolus insulin which is Lispro, that is Humalog, or Aspart, which is Novolog or Novorapid, or Epidra, that is Glulysin, 3 times just before food. And the most preferred therapy since decades remains insulin pump therapy. There are 4 major challenges in the treatment of type 1 diabetes. And these challenges are probably the reason why majority of those getting treated for type 1 diabetes never sustain the targets of therapy. And unfortunately, in many countries, type 1 diabetes patients doesn't survive longer. So unfortunate, even more than 90 years after the discovery of insulin. One major challenge is with resources. Many a time, the child or the parent or the adult with type 1 diabetes cannot afford the newer devices, the newer analog insulins, and cannot afford the self-monitoring of blood glucose on a continuous basis. It is extremely hard or impossible for the doctor and the diabetes team to educate them on the use of insulin, the techniques of injection, the monitoring, and the carbohydrate counting. And this clearly explains the fact why the diabetes remains uncontrolled and why these young children succumb to complications and some of them even die, despite the fact that the government or other agencies are providing free insulin and diabetes supplies to them. Very, very unfortunate situation. And the 4th challenge, the magical remedies prevailing in several parts of the world. Somebody will promise a cure for diabetes. Somebody will promise a diabetes therapy free of injections. And the parents or those with type 1 diabetes may get attracted to such advertisements or promises, and they may discontinue insulin and other therapies for a while. And within a couple of months, they may develop very serious consequences of diabetes and may even die. The success of treatment of type 1 diabetes depends on education. Education of the public, education of the parents, education of children with diabetes. Children spend most of the time in schools and colleges. Hence, the teachers in the schools or the selected teachers in the schools should be educated on the emergency management of diabetes, and they should be permitting children with type 1 diabetes inject themselves in the school, monitor with the glucometer while at school or in between the classes, which seldom happens nowadays because of lack of awareness among the teachers in schools and colleges. And going by the international recommendations and the ADA recommendations, for successful treatment of diabetes, we require a trained team, continuing education of doctors and those involved in the team, and the education to be passed on to the caregivers and to the patients. The use of electronic data and the use of modern devices for the treatment as well as monitoring the blood glucose and delivering the care according to the international treatment guidelines whenever possible. Thank you so much for your patient hearing. Until next month, bye bye from the JDC Diabetes Germs team from Kerala, India. Bye bye.